Hello everyone and welcome to today's webinar. This webinar is what parents need to know about food allergies in schools. I'm Linda Mitchell and I'm president and founder of Kids with Food Allergies Foundation, and I have the privilege of being your moderator today. Today is the second in a series of monthly webinars we will be offering on a variety of topics, both medical and non-medical in nature. I want to extend a special welcome to our members with a special shout out to our donors and family members who support the Kids with Food Allergies Foundation with their membership subscriptions and donations. Your financial support allows us to create new programming like we have today. We've developed this webinar series specifically for parents of children with food allergies. We've been working diligently this year on new projects like today's webinar because we know that educating families about practical food allergy management strategies saves lives and improves the quality of life for children and their families. Today's topic is such a timely one and so relevant for families with children heading back to school soon. Sending off a child off to school with food allergies requires a lot of advanced planning as well as understanding what exactly to prioritize and work on to make sure that your child is safe while in school. We have a wonderful speaker today, Dr. Michael Pistiner. I've known Dr. Mike for several years now, dating back to when I met him at an allergy conference and he asked how he could help. As a passionate patient educator, an accomplished pediatric allergist, and a dad to a son with food allergy, he's since taken on the role of the chair of KFA's medical advisory team, and he's doing an amazing job. I also want to welcome Nancy Palmier-Swendrus, RN, CSN, who's a certified school nurse and the program coordinator for the University of Michigan's Food Allergy Service. Nancy is also here representing our KFA medical advisory team, and she'll be available to add her comments and answer questions at the end. Before we get started, I want to share a few important housekeeping details with you about this webinar. While I run through those, I'll put a quick poll up for you to take. First of all, today's webinar is being recorded. You will receive a follow-up email from us within 48 hours or so. It will give you a link for you to view this webinar again or share it should you choose. Next, today's webinar has a very large audience, so you're in listen-only mode. But we do want today to be interactive, so there will be ways for you to get involved, like taking this poll like we have up right now. In addition, you can ask us questions through the question pane in your GoToWebinar control panel. You can also share comments and thoughts with us there as well. Dr. Mike and Nancy have also agreed to have a Q&A session after the presentation. We'd love for you to stick around for the Q&A because if you do, not only will you be able to hear the answers to their questions that you have submitted, but you will also be eligible for some giveaways that we have. Today we have 3 copies of food allergy musician Kyle Dine's children's CDs and 3 copies of Dr. Mike's children's book, Everyday Cool with Food Allergies, to give away to recipients picked at random from those still in attendance at the end of this webinar. When we end this webinar, you will see a survey. Please share your impressions with us as we will take your feedback very seriously to shape the future direction of our webinar series. We also want to hear if you have ideas for future topics and if you have certain times of day that work best for you. So without further ado, I'd like to introduce today's speaker, Dr. Mike Pistiner. Michael Pistiner, MD, MMSC, is a pediatric allergist and medical director of shared medical appointments for the Harvard Vanguard Medical Associates, as well as an instructor of pediatrics at Children's Hospital in Boston. He is the father of a child with food allergies and serves as a voluntary consultant for the Massachusetts Department of Health Schools Health Services. He is a fellow in the American Academy of Pediatrics, where he is on the Council of School Health and the section of Allergy and Immunology, and he's also a member of the American Academy of Allergy, Asthma, and Immunology, where he's a member of the Adverse Reactions to Food Committee. He's a chair of KFA's Medical Advisory Team, and he also serves on the Board of Directors for the Asthma and Allergy Foundation of America New England chapter. He's also a member of the National Food Allergy Management and Education Advisory Board, and is the author of Everyday Cool with Food Allergies, a children's book, and is the co-creator of allergyhome.org, a website that provides free training modules designed to increase food allergy awareness in the community. So, Dr. Mike, welcome. Thank you so much for being here with us, and I would like to hand the virtual mic over to you.
To take a peek at these polls. to see who our audience is. Excellent. All right, so the majority of us have kids kindergarten age through elementary school, and we also have some preschoolers. So the target audience of this talk, a lot of the talk is really going to be focused on school-age children, but it will be applicable to children attending early care centers as well. You'll notice that a lot of the focus of school-based management of food allergies is really going to fall on the school nurse, and in many of these early child care centers there aren't school nurses. In the case that the school nurse is not present, then administration will be the people who will be taking on that role, just so as we move forward in this talk, that will be a little bit more clear to you. So just to remind you all, this talk is for educational purposes only. Prior to making any changes in food allergy management, please discuss this with your healthcare provider. So, as we all know, food allergies are a growing national issue. Food allergies are estimated to affect between 4 and 6% of U.S. children, and some other studies show even higher percentages. Almost 90% of schools had one or more students in it with a food allergy. All right, I'm just waiting to catch up with me. As we all know, with food allergy, next slide, please. So as we all know, with food allergy comes uncertainty, and issues are constantly coming up about what is a risk, what is not, which interventions are necessary, and which are not. Parents of some children without food allergies may be afraid that their children's rights are being ignored. Parents of children with food allergies may be afraid for their child's safety and self-esteem. Unchecked, these fears can lead to anger. Fear and anger divide communities. By the end of our time here today, I'm hoping to address some of the uncertainty of food allergy management in school and replace it with facts and empowerment. I hope to highlight practical food allergy management strategies that can maintain safety while at the same time can maintain quality of life. As many of you are already experts, I'm hoping to give you the words to explain necessary food allergy management strategies to others. And I do recognize that you already know many of the basics. I'm hoping also to give advice that can promote a positive partnership with your entire school community. Now, let's review how to explain the basics of food allergy. A food allergy is an abnormal immune response to most cases of food protein. The most common allergens are milk, egg, peanut, tree nut, wheat, soy, fish, and shellfish. Symptoms can vary: rash, itching, flushing, hives, lip, tongue, throat, eye swelling, red, watery eyes, belly pain, cramping, heartburn, vomiting, diarrhea, sneezing, hoarseness of voice, coughing, wheezing, chest tightness, shortness of breath, irritability, sweating, dizziness, blue skin color. These are some. The majority of allergic reactions occur within minutes to a few hours after exposure to the offending food. Anaphylaxis is a severe, life-threatening allergic reaction. It can start with mild symptoms and quickly progress. Please note that some people may not have skin findings before or during an anaphylactic reaction. Epinephrine is a medication that is first line. It is the treatment of choice for anaphylaxis. It works quickly, but in many cases it's temporary. In addition to food allergy, there are other causes of anaphylaxis, including stinging insects, latex, medication, exercise, environmental triggers, cold exposure, and in some cases the cause is unknown. If your child has any of these other allergies or issues, please discuss the appropriate management with your physician and school nurse. Now for some food allergy facts in school. In one study, 1 in 6 children with food allergies had allergic reactions to food allergens while in school. Data collected and analyzed by Massachusetts school nurses demonstrated that 25% of those who required epinephrine for the treatment of anaphylaxis in Massachusetts schools had no known diagnosis of allergy. These statistics drive home the importance of all staff being able to recognize allergic reactions and anaphylaxis. Although rare, food allergy-related deaths do occur. The majority of fatal and near-fatal reactions were caused by unintentional ingestion with a known food allergen. Significant risk factors are being allergic to peanut or tree nut, being an adolescent or young adult, having asthma, having had a prior severe allergic reaction, relying on antihistamines, and having a delay in the administration of epinephrine. Because food allergy management is a constant need, children with food allergies need to do things a bit differently than children without. These differences, along with other issues that come along with having a food allergy, can have very real emotional and social implications. A recent study demonstrated that close to 35% of kids over age 5 with food allergies have been bullied, teased, or harassed because of their food allergy. They can have fear of adverse events and death, fear of ridicule, and some can experience social isolation, and some may have limitations in participation in activities. A recent study looked at emotional and social concerns of teens with food allergy. They found that the most concerning troubles to these kids were limitations in social activities, limitations in food choices, feeling as if they were a burden to others, and others not having enough education about food allergies. Important key points for schools to consider are the first-time allergic reactions can occur in school. Fatal and near-fatal food-induced allergic reactions are rare but do occur. Early recognition and treatment of anaphylaxis is imperative and can be life-saving. Food allergies have a very real impact on children. Schools need to have solid, well-thought-out policies. Extreme measures are not necessary. Allergic reactions can be prevented and dealt with reasonably while maintaining quality of life of not only the child with food allergies, but other children as well. How does a school pull this off? How do we do this? First off, awareness and education in the entire school community is an absolute must. In the perfect world, all schools nationwide will work towards providing school-wide food allergy awareness. Very similar concepts can and should be taught to all staff, all parents, the parents with and without children with food allergies, and in a developmentally appropriate way to all students, both with and without food allergies. With awareness and education can come understanding, and with understanding can come support and increased safety for children with food allergies. Today, we'll take a step together in increasing community awareness. So let's dive right in. I like to simplify things a bit by breaking up food allergy management into two parts, prevention and emergency preparedness. For this, I came up with the acronyms ACT and REACT. Someone will need to act to prevent accidental exposures. They'll need to avoid, communicate, and teach. And they will also be prepared to react to allergy emergencies. They will recognize anaphylaxis, know how and when to give epinephrine, and activate emergency response. These are the same basic management skills that are not only important in school, but must be applied to all settings and at all times. To help ensure that effective food allergy management strategies are implemented on a constant basis, there are 3 tools and resources that can be utilized. These will be invaluable to you. The first of these tools is the Emergency Care Plan. It's also known as the Food Allergy Action Plan, Allergy Action Plan, and Emergency Action Plan. It's a care plan provided by your healthcare provider. It's individualized for your child and clearly shows which allergens need to be avoided and which symptoms need an epinephrine autoinjector. Make sure that you truly understand the action plan and, importantly, that it's written and presented in a way that not only a school nurse, but also non-licensed staff can read and understand. Keep in mind that the non-licensed staff members, also known as delegates in some states, although they've been trained and in some cases can give an epinephrine autoinjector, in many locales and states, they cannot give medications like antihistamines. If you have any questions or concerns, please discuss this with your healthcare provider and take these points in mind when you guys are coming up with the allergy action plan. Also, make sure that the action plans are kept up to date. Discuss having a copy or copies available for all staff who are responsible for your kids' care. So what you see up on the screen here is an example of one slide back there is an example of a widely used emergency care plan created by the Food Allergy and Anaphylaxis Network. I suggest that parents not only submit a copy of the action plan to school, but also carry it around with your epinephrine auto-injectors. So as food allergy awareness has been spreading across the country, more and more states have developed effective guidelines to help implement management strategies and regulations. Additionally, guidance documents are also available, and in the next several months, national guidelines will be available to help guide school policy in states where they don't have their own state guidelines. These guidelines and guidance documents serve as an excellent foundation to implement school policies. What's great is that recreating the wheel and needing you guys, the parents, to go in there and take responsibility of implementing and coming up with these management strategies is becoming something of the past. Now, perhaps the most important resource available to you is your school nurse. Your school nurse can best serve the role as food allergy champion. They have the appropriate training and responsibilities to implement food allergy policies and to coordinate and give staff and community trainings. They are the key and important players in dealing with emergency situations and play an absolutely critical role in the management of anaphylaxis, especially in the person without known allergy. So partner with your school nurse and work with them to partner with your entire school community. They will be invaluable and can act as liaisons when communicating with others, especially when it's about things that can be a little difficult, like new school policies. So currently, full-time school nurses are not available in all U.S. schools. In some cases, districts have limited resources. In cases when there is not a full-time school nurse available, then there should be a designee who has been trained to appropriately manage children with food allergies. So talk to your school nurse or administration about how food allergy management and emergencies are dealt with when the school nurse is not present. All right, so now let's get into the nitty-gritty. We will start by discussing what steps can be taken to prevent allergic reactions from occurring in school. We need to act to prevent accidental exposures to allergens. A, avoid. C, communicate. T, teach. We will start with strategies to avoid exposure to allergens in school. To avoid exposure, we'll need to get to know the different ways a child can come in contact with food allergens. Next slide, please. The most important of these is through the mouth, breathing it in, and by touching the skin. Other routes that need to be considered are through the nose and the eyes. Through the mouth is the most common form of contact that leads to food-related anaphylactic reactions. All right, so how much does it take? Depending on the child, even a small amount can cause a severe allergic reaction. Therefore, strict avoidance is recommended. Follow the recommendations of your allergist or healthcare provider and communicate this to your school. Label reading is the key ingredient to avoidance. Each label should be read each time a person with a food allergy is going to eat a product. Anyone responsible for serving food to a child with food allergy needs to be knowledgeable about labeling laws and their pitfalls. Many parents choose to send their child to school with lunch from home. For those whose children are eating food provided by others, all avoidance strategies need to be implemented. That's beyond the scope of what we can talk about today, and for further information on label reading, please, you could check allergyhome.org. We have a label reading module. Now, as far as those pesky advisory statements, we recommend avoiding products with advisory labeling. The statement's written in numerous formats, and there's no regulation. Examples may contain traces of, produced in a facility, also manufactured on equipment, etc. One small study demonstrated that 7% of products with an advisory label for peanut had detectable amounts of peanut in them. They also found that the terms used didn't correlate with allergen levels. Similar studies had very similar findings. Hidden ingredients are not an obvious component of food. Oftentimes, the person eating the food has no idea that this may be contained in the item. but the presence of the ingredient is known by the person preparing the food. Just looking at the food isn't enough. The key to avoiding accidental ingestion is labeled reading. It's important to teach children with food allergies. If there's an item that doesn't have a label, it's safest to avoid. If you can't read it, then don't eat it. This issue often comes up with outside foods and baked items, which can be a source of hidden allergens. For a list of common foods that have hidden ingredients, you can find this more in some of the modules in Allergy Home. So now, food sources also make it into the classroom in non-edible items. Some of the non-edible items found in schools can be finger paint, Play-Doh, shaving cream, paste, latex gloves, bean bags, furniture, pet food, bird feed, as well as many others. Also keep in mind that there may be certain class activities where allergens are used inadvertently, such as science experiments, art projects, math lessons, and cooking classes. Skin contact is another way to have exposure to food allergen. 2 studies looked at the effect of skin contact with food allergen. In both studies, the subjects were allergic to peanut and had peanut butter placed on intact skin. Although local rash was seen in about 1/3 of the subjects, no one experienced a full body or severe allergic reaction. Keep in mind, though, that if somebody with a food allergy were to touch an allergen with their hands and put it in their mouth, it's as if they're eating it. This is very relevant in young children who are exploring their environment with their hands in their mouths. Although the above is reassuring, it is always necessary to prevent skin contact with allergens. Lotions, creams, some soaps, and other topical items may also contain food allergens. Reading the labels for these is important as well. Another way to come in contact with food allergen is by inhalation or breathing it in. Some people with food allergies are often afraid to breathe the air because it may contain an allergen. Keep in mind that the majority of allergic reactions occur when a food is eaten. To further address this issue, a small study was conducted on children with peanut allergy. Peanut butter was held 1 foot from the noses of subjects for 10 minutes. None of the children experienced an allergic reaction. The smell that we can perceive when somebody's eating a peanut product is called a volatile organic compound. This is not a protein. As mentioned earlier in the talk, proteins are the most common cause of allergic reactions. Although the information on the previous slide is very reassuring, respiratory exposure to food allergens can cause allergic reactions. There are reports of non-life-threatening reactions reported on airlines when many bags of peanuts are opened at the same time. There have also been deaths associated with inhalation of actively cooking foods, including fish, eggs, legumes, buckwheat, milk, and others. So take caution with powdered milk, peanut flour, small particulates of food, really anything that can be aerosolized, that can go up in the air that we breathe in. Cross contact. This is the presence of unintended food allergen. What's that kid doing on those springs? Exposure to an allergen by cross contact is a common cause of allergic reactions. Cross contact of food allergen can occur from one surface to another, from food to food, and with transfer of saliva. Allergens can withstand heating and drying. If a person is then exposed to these allergens, especially by mouth, it may be enough for an exposure to cause a severe allergic reaction. Routine training for all staff about sources of cross-contact and prevention of cross-contact and subsequent exposure is essential. So how cross-contact happens, some examples of some objects that can be common sources are kitchen slicers, deep fryers, buffets, salad bars, splatter from food, garnishings, sanitizing dip buckets, high chairs, tabletops, hands, utensils, dishware, cups, water bottles, sponges, and dish rags. And really, these are very common sources of cross-contact. Now, in the case of the sanitizing dip buckets, if a clean utensil was put in the sanitizer, but a utensil with food allergen was also put in the sanitizer, then the clean utensils could potentially have cross-contact with that allergen. A very similar case is seen with sponges and dish rags. If these clean sponges or dish rags were used to clean off a tabletop and then used to clean an additional table, Then you have the potential to spread the allergen from one table to the next. Using disposable wipes or rags is preferable. Next slide, please. Saliva, whether from a person or a pet, can contain allergens and therefore can be a source of cross-contact. For this reason, sharing of water bottles, utensils, sucking toys, instruments, anything that goes in the mouth can become a source of cross-contact. If students have contact with pets, keep in mind that pet food can contain allergens, and checking on the ingredients will be important. Schools will need to keep aware of the different developmental levels and capabilities of each child. There are going to be different issues of cross-contact with different age groups. As mentioned earlier, younger age groups explore their environment with their hands and their mouth. They're also less capable of implementing their own self-management skills, while the older kids are able to wash their hands before they eat. They can read labels, and they can implement their own avoidance strategies. New issues start coming up for adolescents and young adults, which include sharing beverages, sharing lipstick, and open-mouth kissing. Preventing cross-contact with cleaning is important. It is best that there's a cleaning protocol to avoid cross-contact. One study looked at what were effective cleaning strategies to clean hands and tabletops. The study demonstrated that soap and water and commercial hand wipes were effective in decreasing allergens on the hands, but hand sanitizing gels were not. The study also demonstrated that soap and water, commercial cleaners, and commercial wipes were effective in cleaning tabletops of allergen. Please note that in this study, adults were the ones using the cleaning products, not children. Children may be less effective in their cleaning strategies. Again, we're going to act to prevent, and the C of ACT is to communicate, another key part of food allergy management. All personnel that assist in the management of students with food allergies should know about the student's food allergy. Partner with your school nurse and or principal to ensure that all necessary personnel are aware of their allergy. As mentioned earlier, provide a clear and understandable emergency care plan completed by your healthcare provider. And it's best to be shared with all personnel who care for your child. Emergency identification jewelry can be very helpful in children who are not always under the care of an adult. There should also be a way for the responsible staff member to contact the school nurse and or emergency services. Have an open line of communication with your school nurse, teachers, and other parents. At times, it can be really useful to use your school nurse as a liaison, especially when there seems to be a breakdown in understanding or communication. Attempt to use fact-based information and attempt to avoid emotional responses when working through issues as they come up. It's also worth requesting that you be made aware of any events where food is served. It's really important to have an open line of communication also with your child. Check in with them. Avoid using language that may be scary. Encourage them to be open with you about their practices, their mistakes, and their fears. Foster open communication between your child and your child's teachers, the school nurse, and their peers. Encourage your child to bring any concerns to a staff member's attention, symptoms, or an accidental exposure. In general, encourage an openness about their allergy. Have frank conversations with your child that bullying in any form is not okay. Again, we act to prevent. The T of ACT is to teach. We need to teach to appropriately manage food allergies. You'll need to lead by example and model the behaviors and attitudes that you want your child and their school community to implement. Work with a school nurse to educate children and parents about the presence and needs of children with food allergies. This is where we've really had exciting gains across the country. Only recently, and still perhaps in many schools, the responsibility of educating students and parents has fallen on the shoulders of parents of children with food allergies. Discussions and lessons on necessary food allergy management can give understanding and empathy. The opportunity to explain why some kids need to do things a bit differently can go a really long way. This can foster a more supportive environment and hopefully one that will curtail bullying. For some children, being the focus of class discussion or activities may be exciting and rewarding. For others, it can feel embarrassing and isolating. If possible, help your child and your school figure out which approach will work for you guys. Are you going to choose a child-focused approach or a more anonymous approach? Partner with your school nurse and teacher to figure out what works best. For more detailed information, take a look at the Educating Students and Educating Parents Without Food Allergy modules for schools.allergyhome.org. Now, emergency preparedness. Now that you're familiar with strategies for prevention, we'll move on to the concept of emergency preparedness. Preparedness, being ready for an allergic reaction, is a key principle of food allergy management that needs to be implemented. Just like prevention, at times and at all times and in all situations, anaphylaxis needs to be treated quickly with life-saving epinephrine. It's absolutely essential for someone to be able to quickly identify allergic reactions, treat appropriately, and get additional help. There must always be a person who is ready to react. Recognize anaphylaxis, give epinephrine, and activate emergency response. Call 911, tell them that there's a child with anaphylaxis, and then notify doctors, parents, as per the allergy action plan. What many of us who've been involved in school advocacy and education are encouraging is pan-education. Teach everyone. All staff should be able to answer the question, what's your role in emergency preparedness? Anyone who interacts with students, staff, or visitors should be familiar with the symptoms of anaphylaxis as well as less severe allergic reactions. There should be an emergency protocol and staff should know their role. Some staff will be trained under the direction of the school nurse to recognize and treat anaphylaxis in those with a known allergy when the school nurse is unavailable. Keep in mind that different schools will have different policies, and these will also differ state by state. Each school will need to come up with a policy, but the policies don't need to be the same, and it is going to depend on the resources of each of the individual schools and the student body. As long as allergic reactions can be recognized and treated appropriately, then these policies should do. The R of REACT is recognizing anaphylaxis. Staff should be aware that children can experience allergic reactions in very different ways, and each child may have different reactions from ones that they've had in the past. Keep in mind that anaphylaxis can start with mild symptoms, but can progress quickly. Anaphylaxis, a reaction that can involve more than one organ system like skin, lungs, heart, gastrointestinal, and brain, may start off mild in severity and quickly evolve into a more severe reaction that can be more difficult to treat. Early treatment of anaphylaxis is life-saving. All staff should be taught the signs and symptoms of anaphylaxis. For the interest of time, I will not go through the symptoms, but for those interested, there is an emergency preparedness module available on allergyhome.org. And so these are just a few of the symptoms that can suggest anaphylaxis, and we'll just go to the next slide. We'll move forward. And we'll move forward. Two more. And one more after this. Be aware that small children can have a hard time describing their symptoms to adults and may do so in unexpected ways. Some children can complain of funny feelings in their mouth or throat. One example can be not being able to get the taste out. Once anaphylaxis is recognized, then we move on to the E of REACT, the life-saving epinephrine. Epinephrine is the treatment of choice for anaphylaxis. For those with a known allergy and an auto-injector in some states, a trained non-licensed staff member can administer an epinephrine autoinjector in the event that a nurse or physician is unavailable. Please discuss your state regulations with your school nurse or principal. At the time of creation of this module, in most of the country, for those without known allergies, non-licensed responders cannot administer epinephrine. Rapidly getting the school nurse or school doctor and contacting emergency services is critical. The big take-home point here is that emergency protocols may differ for students with known allergy and those without. Again, this is going to vary state by state and school by school. But this is the take-home point for all of you guys out there. Make sure that you have completed all necessary paperwork for your child so their allergy will be dealt with in the most efficient and swiftest way possible. All should know that epinephrine is the first-line treatment of anaphylaxis. It works quickly but is short-acting. Further evaluation and management in the emergency department is essential. Also keep in mind, especially when it comes to emergency care plans, that antihistamines are second line and do not stop or prevent anaphylaxis. At the time of creation of this talk, EpiPen is the only readily available brand of epinephrine autoinjector in the United States. Typically, autoinjector companies provide free training tools on their websites. Taking a look at these can show some of the steps involved in giving epinephrine autoinjector. Autoinjectors come in a junior dose as well as a senior dose, and this is going to be as per discretion of your healthcare provider. So for the interest of time, I'm not going to go through the steps required for autoinjector administration, but hands-on staff training is key for confidence and competence. For more information on how to give autoinjectors, there's also a training module for these on the Allergy Home website. We're now making the recommendation that people have 2 doses of epinephrine available. A recent study showed that 12% of kids with food-related anaphylaxis in Boston area hospitals needed a second dose of epinephrine. Also keep in mind that some schools can be far from the nearest hospital or medical center, and it can take time for an ambulance to arrive. Ask your healthcare provider to arrange for you to have 2 available doses at all times. Schools should have epinephrine in a secure but accessible location. Location of autoinjectors will vary school by school and state by state. In some cases, self-carrying is appropriate. Location and storage will depend upon resources and policies. Discuss this with your school nurse. If at all possible, avoid extreme temperatures. Attempt to keep it at around room temperature, and don't store it in your glove box or any place where it can bake and heat. And this will be the same in schools. So the active react is activate emergency response. Staff should call the school nurse if available and 911 or local emergency medical services. Students should be taken to the emergency department via ambulance. This is important because the child may need additional care and can also experience a second phase of their reaction called the biphasic response. After epinephrine is administered and after 911 is called, then the school should contact emergency contacts as per the emergency care plan. While awaiting EMS and after giving epinephrine, if possible, do not have the child or adult rise to an upright position. There have been cases of deaths that have occurred when rising someone who just experienced anaphylaxis upright. So now, after a reaction has resolved, make sure to contact your healthcare provider and arrange for a follow-up visit. Review the emergency response with your school nurse and principal, and review where there may be a need for updating and where things could have been done differently. Work with your school and your child for a smooth return. All right, now let's put together what we've learned. Remember that prevention and preparedness need to be implemented in all times and all settings. Now we'll briefly focus on each of these school-specific settings. Although what I'm going to talk about and what we've outlined really is best practice and based on guidance documents. These are not requirements. Many schools may implement effective strategies without implementing absolutely all of these mentioned. The classroom. Data from mandated reporting of epinephrine administrations in Massachusetts schools suggests that the classroom is the most likely location in a school for an allergic reaction to occur. The school should keep easily accessible but secured information about the student's food allergy in the classroom close to their teachers. Also, they should consider the storage of epinephrine in a well-defined and secure and accessible location. It's safest if the child with allergies eats only what they bring from home. There should be no sharing or trading as a rule. Someone should examine all food brought into the classroom for potential allergens. And you should consider providing safe snacks in the event that there was an unexpected circumstance and food was forgotten. Also, the school can encourage an eating area that's free of allergen. Designate an allergy-friendly table or desk. Appropriate table and chair cleaning before and after eating should occur. Appropriate hand washing before and after eating. And it's safest to give non-food incentives for prizes, gifts, awards. Avoiding the use of identified allergens in class projects, parties, holidays, and celebrations, as well as arts and crafts, science experiments, cooking, snacks, rewards, and other purposes is best. And class materials should be modified as needed. The cafeteria can be challenging as there's many children eating all at once, and there may be a lot less supervision. So schools should encourage hand washing before and after eating. They should designate an allergy-friendly table, wash tables and chairs after each meal with soap and water or common household cleaning agents, but not use, as I mentioned earlier, the rags, sponges, or dipping buckets that could be sources of cross-contact. Disposable methods are best. And then consider storage of epinephrine in an accessible area close to where the children are going to be present. And as in all settings, no sharing, trading food, and bullying should be stopped. As far as phys ed and recess, someone trained to recognize and treat anaphylaxis should be present. Epinephrine should be easily accessible. There needs to be a way to communicate with the school nurse and to access emergency medical services. Kids with allergies shouldn't be excluded from physical activities or recess. Cleaning hands before and after handling or consuming food is important. Now, as far as school-sponsored events and field trips, preparation is really important because it's going to take a lot of planning. So the teacher or whoever is going to be organizing these should discuss and plan well in advance. When planning for it, they should determine that the location is safe for children with food allergies. They should ensure that the events and field trips are consistent with food allergy policies. And kids with food allergies should not be excluded from these field trips. It would be nice if they invite you, but don't feel that you need to go. Your presence should not be required for a field trip. Designated adults should be there to assist in avoiding the allergen, recognizing anaphylaxis, and administering epinephrine. While on the trip, packaging meals to avoid cross-contact, using the appropriate cleaning strategies will be really important. And as mentioned before, and in all circumstances, there needs to be people who can pick up on an anaphylactic reaction, treat with epinephrine. The nearest emergency department should be, the staff should know how to reach them and where they are, and there needs to be a means of communication. Now, as far as transportation and bus, eating should not be allowed, with exceptions of children with special needs, but this will be worked through. with the nurse and administration. Transportation staff should be trained to recognize allergic reactions and implement emergency procedures. It's recommended that bus drivers be trained in the administration of epinephrine, but this is not something that is widely occurring in the United States. Consider storage of epinephrine in an accessible, well-defined, and secure location, and working through this with the bus company and school nurse and administration will be something worth doing. And as always, there needs to be a means of communicating with emergency medical services. Now, as far as before and after school activities, it'll be important for you to inform the program coordinator of the child's allergies as well as other medical conditions. And the same avoidance and preparedness strategies will need to be put into place here. Now, for cases where school policy is not adequate, the creation of a 504 plan can help ensure that food allergy management strategies are in place that can keep food allergies from interfering with the child's education. Detailed information about 504 plans and the Americans with Disabilities Act are beyond the scope of this talk. But just know that these are things that are in place when what we just talked about isn't working. Please discuss this and these options with your allergist or other healthcare provider, and please seek additional information from Kids with Food Allergies, FAN, and FAI. All right. Now let's review some of the final take-home points. We can act to prevent accidental exposures to allergens. Avoid, communicate, and teach. Be prepared to react. Recognize anaphylaxis, give epinephrine, and activate emergency response. Use your resources to help ensure that effective food allergy management strategies are implemented on a constant basis. These three resources, the action plan, your school nurse, and guidelines and guidance documents will be really helpful. Partner with your school community. All right. Well, thank you, and I think it's going to be a great school year.
Well, thank you so much, Dr. Mike. That was just terrific. Wow, so much information. It's such an important topic for families to know the key issues to focus on when sending their children off to school. I know as a parent myself, it can be a really nerve-wracking time and an emotional time for us. I know personally my little first grader had a reaction at school, so I know how important it is to be prepared so that everybody is trained to know what to do right when the time comes at school. Now what I'd like to do is invite KFA Medical Advisory Team School Nurse Advisor Nancy Palmier-Swendress to add closing comments. As I mentioned earlier, Nancy is the Program Coordinator for the University of Michigan's Food Allergy Service, and she's also a certified school nurse in Ann Arbor, Michigan. Ann Arbor, Michigan was one of the first school districts in the country to develop food allergy management policies, so Nancy really understands the important role of schools and with school nurses in keeping students with food allergies safe. Nancy has lots of experience in this area. She's committed to educating families about food allergies and to help advocate for them in the community, at school, and in the workplace. She has extensive experience working with staff and families at schools, at camps, and even at universities. So welcome, Nancy. I'm glad you're here with us today, and I'd like to see, if you have anything to add from after Dr. Mike's presentation today.
Thanks, Linda. Thanks to all of you who have taken the time to participate in this most important presentation. We are thrilled that to have the ability to speak to you with such a large and diverse audience across the United States. My practice philosophy is advocacy for the family, empowerment of the child, in partnership with all the shareholders, especially the kids' peers and the staff and the school staff. So I think we're ready to answer some of the questions.
going to see. Okay, Nancy, what I'm going to do first is the giveaways, if that's okay with you, and then what we'll do is we'll get back to questions and answers after that. Okay, terrific.
Great.
So as promised, thanks. What I'd like to do now is giveaways. We have 3 copies of Kyle Dine's CDs for children. If you're not familiar with Kyle, he's an entertainer for children who sings food allergy education music. They're fun, they're upbeat, they're empowering, and he's donated 3 copies for us to give away. And then Dr. Mike has written a children's book as part of the No Biggie Bunch series, and he's donated 3 copies of his book to give away as well. So what I'd like to do is to see if Melanie Carver is available, who's been helping me along tonight with today with all the technical aspects, to see if she can go through the registrants and pick some random winners of these giveaway items. Okay, so I'm reading through. Let's see. Winners. Okay. The first 3 copies of Kyle Dine's CDs are Amanda Barton, Julie Tuff, and Sue Harrison. And Dr. Mike's book goes to Sharon Wills, and wait for some more names. Gretchen Williams, one more, Jonathan Calland. So we have all of your email addresses because of your registering for this webinar, so we'll be in touch by email to get your mailing address and send you copies of your giveaways. So thank you again. And then one of our corporate partners, Medical ID Marketplace, has a special discount if you're interested in medical identification jewelry for back to school. They have other medical identification items as well. So if you're interested, you can go to their website, which is medicalidmarketplace.com, and use the discount code KFA15, and you'll get 15% off your entire purchase. And that's good until August 5th. We'll also be sending you information about this in the follow-up email that we send to you as well. So with that, I'm just going to go ahead now and get to that Q&A that Nancy had mentioned. It's already 3 o'clock, so since we've run a little bit late, if you'd like to stay for the Q&A, we'd love to have you. We'll probably go for another 15 or 20 minutes. We've had a lot of questions come in, so if we don't get to them before the end of the day, then what we'll try to do is to summarize some in the future in a blog post on our website. So let me see if we have the first question to get started. Let's see. Hold on for just a minute while we catch up with everybody. I know one of the first questions that we got was, what are some practical ways to encourage building awareness among staff, students, and parents of non-allergic children? Dr. Mike, do you want to take that one?
Yeah, that's a topic really near and dear to my heart. And part of the hard part is the school nurse or representative really can't be all places at once. And so it really can be a very real challenge for the school to be able to provide the necessary education to all these parties. And as I mentioned briefly before, I wish I had more time to go into it, which is just having this increased awareness and having the parents of kids without food allergies understand why it is that we're doing what we're doing, and having the children without food allergies understanding why it is that we're doing what we're doing to protect these kids with food allergies really goes a tremendous way. And so trying to come up with ways to educate these folks and do it in a fashion that doesn't feel like it's being jammed down their throats is really tricky. And that's part of what John Lee and I were trying to do when we created allergyhome.org, and then we made a specific school site called schools.allergyhome.org, where we have created training modules to try to target these populations, very similar to what I just gave to you guys, but this is specific to the parents without food allergies, hopefully brief enough that they could observe it when they come in kindergarten, at a PTO meeting, something that the school principal could potentially send it a letter to go home saying that there are children with food allergies present, and there's some strategies that are implemented in the school, and this is why. Also, staff training and nurse training is something that that we found is really important in trying to increase not only the awareness, but also in the case of staff and nurses, giving them very specific tools that are right at their fingertips. A lot of the state guidelines and guidance documents are absolutely fantastic, and they have a whole lot of information in them, but sometimes it's not so easy for a teacher to be able to get access to it and have the time to. So that's what we tried to do, is make these free online modules that people can have access to that kind of information.
Just in addition, a practical component to the whole awareness at schools or preschools is for the family to develop a partnership with the administrators, and then they can go from there to decide on the unique situation of that setting and how that the staff is going to be educated. So if the school is privileged enough to have a school nurse there, there's often at the beginning of the school year professional development time, which will be the time that nurses can then educate staff, or in a preschool setting or a child care setting to even have a parent come in and educate the staff when not a lot of busy time is going on. Another good partnership in these settings are to develop a partnership with the PTO. And if you develop a good, healthy partnership with them, then they can also work with families of non-allergic children.
Okay, terrific. Let's see. How can I best prepare my 4-year-old to enter school and feel safe?
Dr. Mike, I'll take that for a quick second. I think.
Yeah, go for it.
Yeah, I think an important part here is it says right in there, how can I have my 4-year-old feel safe? My experience is if mom feels that the setting is safe, often the child will feel much better about this. So mom has to do a lot of work prior to that child coming to the preschool as a 4-year-old, in partnership with the staff and administrators, and being sure that they do have policies and strategies that are already in place so that their 4-year-old can be safe, which would be that would prevent further accidents, and then for all staff to be prepared to do something accidental exposure that has occurred. So then 4-year-old safe. Dr. Mike, anything else to add?
I'm having a little tough time hearing you. I'm not sure if folks can hear me. But I would also add getting these young ones participating in their own food allergy management also is going to be really important in their empowerment and their own confidence. So getting them involved in age-appropriate ways with knowing that they wash their hands before they touch their mouth, rub their eyes, pick their nose, knowing that they're going to have an adult check and make sure that a food is okay by reading a label, knowing that they don't share food or utensils, knowing, and there's others, and communicating with adults and being able to share their feelings. These are all going to be really important things to get these kids comfortable with their allergy and ultimately be able to then feel comfortable coming into school.
Okay, next question is, should a school plan always be in writing? My son's school doesn't want to put one in writing.
%100% right. Provide that it's written, that it goes to school. And So and taken to school and understood by everybody.
Okay, Nancy, I don't know if maybe you can try repeating that because your voice was breaking up, the audio was a little bit unclear, and I know that you had an important message to say.
Okay. The thoughts about should a school plan always be in writing. The belief is that an individual health plan should be written annually for these children. They should be written by a healthcare provider, and it should go to school with that child, and the staff and administration should understand what the school plan means and then implement strategies for that particular individual health plan for that child.
Okay, thank you very much. What can I do if my son's teacher doesn't take food allergies seriously?
This would be where partnering with your school nurse is really important, and hopefully with your school nurse as a liaison, you can come up with a plan on how to approach this teacher. In almost all cases, nobody is going to want to endanger a child, and sometimes, as we mentioned earlier in the talk, sometimes this lack of awareness is something that some people just have, because understanding and knowing food allergies can be really tricky. And what I found, and I think that probably most of you have found it, is that once people start getting it and see just how tricky it is, then they want to be on board. And so finding somebody to help with that conversation and to be able to have an understanding, get through to that teacher is going to go a very long way.
And Dr. Mike, I agree with that. I don't really feel that there's any teacher that really does not want to take care of that individual student. But sometimes it is merely that they really do not understand the child-specific food allergies. What's hard for teachers is that they have many, many, many students, and many of these students have food allergies, but their individual health plans can be varied. So it's hard for them to understand that for one child they have to do all these, implement all these policies in their classroom for one child with a certain food allergy, and then for the other child they don't have to do that. So sometimes it's just sitting down with that particular teacher to educate them about the specific child's needs. And I've never seen a teacher, once they've had that meeting, that they didn't respect that.
And the hope also is that in the future, as PAN education becomes more and more acceptable and easier to do, these will be conversations that will ultimately not need to happen, because they're going to be happening in large group setting where staff is going to be trained as part of a routine. And so there will be more of an understanding and more of an acceptance of needed management strategies.
Okay, great. Next question, who should we contact if our school doesn't have a school nurse or if the school nurse is not well educated in food allergies?
My personal experience regarding to that would be the leader in that school, so it would be the principal. I would start with the administrator in the school to try to develop a partnership with that administrator and see what other resources are available for the school. And there are sometimes that doesn't work either. So there has to be an administrator in charge of that principal as well. But typically, if you can develop a partnership early on with the administrator, it's best to do that prior to the start of school, because once school starts, it gets very, very busy, and it's hard for administrators to pay specific attention to specific children. But if there is not a school health professional in that school, what happens in the school is really monitored by the principal.
And then also, just to add to that, you can also, and as everybody who has a child with food allergy should do, is partner with your healthcare provider and an allergist if you have one. And if you're not getting what you need from the direction of your school, and you do try that partnership with administration and principal, and that still is not giving the partnership that you need than trying to assist or get assistance from your healthcare provider will be another direction. And then yet another direction is, at least in Massachusetts, not only do we have school nurses per school, but then we have school nurse leaders. And ultimately, if there was one particular person who didn't seem to have an understanding, then there are other people who can help bridge that gap.
Okay, great. We had a couple of people who wanted a little more information about the positioning of a child after they go into anaphylaxis and are given an injection. Do you feel like that's in the scope of what you can answer to?
Yeah. Okay. So now, fortunately, in children, the cardiovascular ramifications of anaphylaxis aren't quite as common as in the adult population. But still, if someone is experiencing anaphylaxis, then they have pretty floppy blood vessels, and if they're stood up, if they raise, then they could have venous pooling. They could have pooling of the blood, and it would be safest for them to remain down. Now, one of the things you want to keep in mind is that if somebody's having a hard time breathing, laying flat back is not going to be wise. Keeping the child comfortable, and then also making sure that if they are vomiting, that their airway is protected and that they don't aspirate, that they don't choke on the contents coming out of their stomach. And so keeping them down and in a position where if they were to vomit, they would not choke is something that is important. And then waiting for emergency services to come to them, as opposed to treating them, getting them up, and walking them to the front of the school.
Okay, great.
Go ahead. Just one quick to add to that, Dr. Mike. That's exactly what we've done at school, is that we treat the child lying down on their side in case they were to vomit, and also if they're not having any respiratory distress, and letting the staff know that it's very important not to move the student until the EMT people come and take over. And like you said, you surely would not move them to get them to the ambulance, but the ambulance needs to come to them.
Okay, great. Well, thank you. You know, it's coming up on 3:15, so I think we're going to have to wrap up the Q&A session. There were a whole lot more questions than we're going to be able to get to, so we'll just see about creating future blog posts or other informational resources based upon your interest. So I thank you all for contributing those questions, and I really hope that the ones that were answered were helpful to you. So in any case, what I'm going to have to do is move on, and what, like I said before, is we'll be sending you a follow-up email with a link to the webinar, and some of you asked for a copy or a link to the study about hand sanitizers, and that is online, and I can certainly make sure we include that in the email to you as well. So we can do that, and then the email will also give you some information about upcoming webinar topics that we have in mind. I did notice that a number of you asked questions that were more of a legal nature, 504 questions, things about inclusion, things like that, and that's beyond the scope of what we're doing today, but it's certainly a topic we can plan on for the future. So I just wanted to let you know that we're not ignoring your questions and concerns about that, but that it's really a big topic that they need to have a legal advisor here to help us with and stuff like that. So, so as I wrap things up here, what I'd like to know is how did we do? What we're going to do at the end of this webinar is to go ahead and give you a link to a survey that you can take and just let us know what you liked, what you didn't like, and things like that. And also, since we've found out that many of you who signed up for this webinar are not members of Kids with Food Allergies, or may not even know that we have a Facebook page, that we welcome you to join our online community, which is on our website. It's free. We also have a really active Facebook page at Kids with Food Allergies. Facebook.com/Kids with Food Allergies, and you can hang out with us there. And then we'll just stay informed with you. And like I said in the very beginning, this programming is made possible through the generosity of donors and membership subscriptions. So if you really like what we're doing and you want to support us, we'd appreciate you considering a contribution at some point in the future through a donation or a family membership. So thank you for being here with us this afternoon. Have a good day. We're going to go ahead and end the webinar tonight. I want to sincerely thank Dr. Mike and Nancy for joining us today and for all of you who participated in the conversation. Have a good day.
Thank you.